Hello, friends, and welcome back to my YouTube channel, Academics at the Rate Critical Care. And today we will discuss some topics of surgical critical care. I make this presentation on behalf of ISCCM in a webinar, and I thought to re record it and upload it in my channel. So, today's topic will be post operative management of a non cardiac thoracic surgery. So when we talk about thoracic surgery, non-cardiac thoracic surgery, we usually include mediostenoscopy, video-assisted thoracoscopy or VATS, sympathectomy, so it's not done frequently nowadays, pneumonectomy, and the surgeries mostly involves thoracic valve, trachea, lungs, and esophagus. What about intensive care? These patients come to intensive care for post-operative medical management. They comes to ICU preemptively if they have an anticipated complications like high-risk patients with a lot of comorbidities or may undergo one lung ventilation when they're anticipating any postoperative complication, or if these patients require organ support in the immediate postoperative period like invasive or non-invasive ventilation or a vasopressor support. As these are challenging surgeries, so preoperative optimization, specifically in terms of pulmonary challenges, is very, very important. And this need to be done in high risk factors like smoking cessation, preoperative education and optimization of physiotherapy, and optimization of different comorbidities like diabetes, hypertension. Now, when you talk about physiotherapy, it is better that the patient learn all those skills and techniques in the preoperative period when his general condition is stable, he's not going through a pain and something, and he's in a mental situation, psychological situation to pick up new skill rather than in the post-op period when he has some amount of effect of the anesthetic drugs or like opioids and he is in some amount of pain to pick up a new skill. Regarding the benefit of smoking cessation, we all are aware that if you stop it immediately for 12 to 24 hours, there will be decreased level of carbon dioxide and the nicotine in the blood, and there will be less amount of sympathetic surge compared to when you can stop it for more than 6 to 8 weeks. Probably will get benefit of immune function and metabolic improvement. There will be overall decrease in the post-operative morbidity and mortality, along with improvement in the pulmonary function test via PFT. So when you're talking about thoracic surgery, there's two ways to approach them. One is VATS or video assisted thoracic surgery or open surgery. It has been shown that in VATS, postoperative complication rate is around 9%, and those mostly includes hemorrhage, empyema, air leak, pneumonia, and surgical emphysema. In the postoperative pain in VATS surgery is significantly less, and as a result, this patient usually have a shorter hospital stay. So what we have to look for is the feasibility because if it is possible, there will be lesser complication rate in the postoperative period, early mobility and discharge. But because these VAT surgeries are technically challenging, a higher bleeding rate and intraoperative complication can be anticipated, specifically in the early phase of the surgery. Now, when you look at the way to closure the suture lines, so there are staplers and glues. Mostly, whenever we are doing a wedge resection, lobectomy, or excision of bullous, there is a risk of prolonged air leak, especially in patient with a COAD. So, if we use stapler in this subgroup of patients, there is an improved air leak, that is lesser chance of air leak. On top of that, there is practice to reinforce the staple line with polyglycolic acid fabric, polydioxone ribbon, bovine pericardial strip, bovine collagen, and recently expanded polytetrafluoroethylene have been used. And along with that, there are options like electrothermal bipolar sealing. But even then, air leak is not a very uncommon complication. It can be inspiratory or expiratory. Expiratory is more common, can be continuous or forced expiratory. Inspiratory leak happens on positive pressure ventilation. If there is no pleural space, we should put them in underwater seal with a chest tube. If there is a space and the connection, the air is not getting resolved, you can consider for a negative suction with an underwater seal. If the leak persists, then we have to consider for a talc application or reopen the surgery for closure. In terms of the intercostal catheter, we usually watch for drainage and the air leak. Postoperative chest X-ray, if shown an expanded lung field, then no suction is applied, even when there is a bubbling through the intercostal tube or catheter. If there is a aspect, as I mentioned, non-resolving pneumothorax, then we apply a negative suction. And nowadays, what we are using something called balanced drainage system. After pneumonotomy patient, we do not apply suction because it may cause shifting of the mediastinum and compromising the venous drainage, increase afterload, and hemodynamic instability. Suction is also applied in case of there is a pleurosis with a talc. And if we are considering something from intervention for long term, then we can consider for Helmich valve container. It helps us for early complete mobilization, ambulation, and discharge of our patient. Now, fluid management is like any other standard surgical patients. We are aware that we have to keep the volume status optimal because in one hand, if there is a hypovolemia, it will lead to hypoperfusion, organ dysfunction, and adverse outcome. On the other hand, if there is a hypervolemia or excess fluid, leads to edema, the whole body, including or maybe organ-specific edema, leading to organ dysfunction and overall poor outcome. Nowadays, what we are practicing mostly, specifically for lung surgery, it is a little restricted fluid therapy. We try to keep the lung little drier, and this patient will need monitoring in the high dependency unit after surgery or a dedicated thoracic unit to optimize their perioperative fluid management. Usually encourage oral feeding as the gut has not been handled and this patient should be able to tolerate feed. We try to keep intravenous fluid at max 1 to 2 ml per kg per hour in the intra and postoperative period, and we strongly try to avoid positive balance in the postoperative period. Studies have shown positive balance beyond more than 1.5 liter or 20 ml per kg is associated with poor outcome. And in between, if there is a hypotension, and if we find that this is because of the anesthetic drugs or vasoplegia, then we consider for a vasopressor. Adequate pain control is very, very important, specifically if they are doing an open thoracotomy, because the pain in the surgical site will prevent the patient from doing deep breathing, coughing, and active thoracic physio. Present practice is multimodal analgesia with a target of opioid sparing. And what are the benefits? It prevents pulmonary complication and cardiovascular complications. Post-operative delirium is reduced, chronic pain syndrome is chances less, and it complies with the chest physiotherapy and ambulation. So presently we are trying to cut down opioids as much as possible. In terms of the techniques or invasive procedures, epidural analgesia is a standard. It includes local opioids along with or without local anesthetics with or without opioid combination. The main advantage is it preserves cough reflex and increases respiratory function. There are other options like paravertebral block. If the afferent pain inputs is predominantly unilateral from the chest or abdomen, then probably can avoid epidural. There are some concerns that if you use epidural, the chances of fluid requirement because of a more vasodilatory state is high, and some surgeons try to avoid it specifically in high risk patients. In paravertebral block, we can place the catheter under direct vision during thoracic surgery, so that would be an advantage in terms of the ensured placement. And when it's been compared with the chest drain loss of local anesthetics, along with intrapleural block, it's shown that the local anesthetic loss is 4 times lower compared to intrapleural block. Along with that, we use opioids via PCA pump or patient control analgesia devices, gives it a higher safety and opioid sparing effect. Along with this, there are options like intrapleural local anesthetics, where you need to inject the drug at a multiple level at the intercostal nerve level, and it depends on patient position, infusion volume, and the type of surgery. And sometimes the volume of drug is very high. There are other options like cryoanalgesia, which are associated with increased incidence of chronic neuralgia, transcutaneous electrical nerve stimulation. And whenever we are doing all this, we should not forget about different systemic drugs like paracetamol, NSAIDs, and narcotic agents. As I mentioned, physiotherapy and early mobilization is the key in terms of recovery. Physiotherapy, along with the help of a bronchodilator or tracheal toileting, can be really helpful. Deep breathing and coughing exercise can be done easily, and with the help of the incentive spirometer, the improvement of the respiratory function can be augmented. If there is inspissated secretion or cough retained, then we can use vibration technique or chest percussion technique along with a cappella. Some patients may need endotracheal suctioning if there's a profuse secretion in the immediate postoperative period without mini tracheostomy. Mini tracheostomy is not a practice nowadays. And all these things are shown to reduce complications like atelectasis, pneumonia, empyema, and deep vein thrombosis. The standard practice is for early removal of chest tube and urinary catheter that helps for active mobilization of these patients. But the aspiration will be a concern when you have to do good physiotherapy, good coughing exercise to prevent aspiration. DVT prophylaxis, like any other standard patients, we can consider for mechanical options are stockings, DVT pump, you can consider pharmacological, LMWH, heparin, and NUAC. Usually in thoracic surgery patient, because by day one the patient will be mobilized, better to go with a stocking rather than DVT pump. Nutrition, we all are aware about the importance of nutrition, specifically in cancer patients, because these patients are malnourished and they usually have a poor nutritional result. So we should resume enteral nutrition postoperatively to the earliest, both for conventional, that is open and laparoscopic surgery in both the situation. Daily protein energy requirements are standard, like around 1.5 gram per kg of protein, along with 25 to 30 kilocalorie dose of in carbohydrate in as per body weight. Usually, it has been shown that better nutritional status and higher protein delivery can improve surgical healing. Micronutrients like vitamins and trace elements deficiency have to be evaluated and replaced accordingly. And we are all aware that uh, patients who are on polymeric feed may not require micronutrient supplementation, but if someone is on blenderized diet, then we definitely have to add micronutrients into their practice, into their daily intake, and also look for micronutrient deficiency clinical symptoms. If a patient is not able to take adequate nutrition or anticipated to fail to take adequate nutrition by next 3 to 4 days, then we can consider for partial parenteral nutrition. We need to remember for oncology patients, if they're malnourished, to start TPN, we should not wait for 7 days. Rather than we should start by 3 to 4 days. What are the advantages of early postoperative nutrition? We all know that reduction in the postoperative infection, reduced risk of microbial translocation in the gut during the hospital stay, morbidity and mortality, favorable outcome in resumption of bowel function, peristalsis, positive nitrogen balance, and substrate tolerance without increased risk of anastomotic lesions or infection. These are the guidelines that have been put forward to manage thoracic surgery patients according to the ERAS principle. ERAS is enhanced recovery after surgery. And they try to focus on different interventions that really can decrease postoperative surgical complications and help the patient to go early, that is, get discharged early, saving manpower, man days. But doesn't matter what you do, there will be complications. And being an intensivist of a surgical ICU, you need to be aware of the complications that is related with a certain surgery, and you have to anticipate them when they are on the way of happening. Can you identify high-risk patients? Yes, there is a way to identify or anticipate pulmonary complications after a surgery, something called flame score. It has two major and minor criteria, three major criteria like dyspnea, chest pain, and administration of oxygen, and four minor criteria like quantity of the bronchial secretion, quality of the bronchial secretion, quality of the cough, how much the patient is able to cough, and quality of pneumothorax. So, what are the pulmonary complications? Pulmonary complications can be as high as 60% after a thoracic surgery, and it is significantly higher compared to abdominal surgeries, where upper abdominal surgery can be 15 to 20%, and lower abdominal surgery is significantly less, maybe less than 5%. Most common complications are pneumonia and atelectasis, and it has a significant clinical and potential economic impact because it increases the hospital stay and ICU stay, and need for recurrent ICU admission, and also can cause mortality. In patients who is undergoing postoperative pulmonary complications, mortality rate can be as high as 30% in certain situations. And so, aggressive preoperative and postoperative cardiopulmonary rehabilitation are the key for preventing this type of complications. Who are at high risk? So, risk factors are age more than 65 years, smoker, associated comorbidities like COPD, congestive heart failure, chronic liver disease, preoperative anemia with hemoglobin less than 10, low preoperative peripheral oxygen saturation, that is room air saturation less than 96%, respiratory infection in the recent past because this patient has a high risk of developing postoperative pulmonary complication including ARDS, intrathoracic or upper abdominal surgeries, duration of the procedure if it is more than 2 hours, and emergency surgery. And how we are differentiating major and minor complications. So minor complications include bronchospasm, atelectasis, and pleural effusion. On the other hand, major complications include pneumonia, that is infective complication caused diagnosed by fever, high count, along with oxygen requirement and productive sputum, thick secretions, or maybe changes in the chest X-ray. There may be an ARDS. There may be respiratory failure in terms of hypoxia or hypercarbia, and there can be aspiration pneumonia. What are the strategies to prevent? So, preoperative assessment and medical optimization, as I discussed, including cessation of smoking, correction of anemia, preoperative chest physiotherapy, shortening the duration of anesthesia if feasible. For prolonged surgeries, lung protective ventilation can with a low tidal volume and moderate PEEP can be really helpful. It has been shown that this intervention, lung protective open lung ventilation, even after for major surgeries, can decrease risk of postoperative ARDS. Obese patients who are requiring high opening pressure can be at high risk. Early extubation. So we have to maintain open lungs in obese patient to prevent atelectotrauma, recurrent opening and closing. Early extubation with complete reversal of neuromuscular blockage, postoperative NIV, prophylactically, not at the end if there is a respiratory failure, and adequate analgesia to have postoperative ambulation and aggressive chest physio. Now, another complications, interesting complications called pulmonary edema. These are called post-pneumonic pulmonary edema can happen up to 15% of cases. The risk factors are age, extent of resection, preoperative lung function, and the other comorbidities. Usually, the onset is within 48 hours of the surgery and they present with a severe respiratory failure. There are diffuse radiographic changes in the plain X-ray. It looks like a pulmonary edema. The mechanism is by ischemic reperfusion injury and creation of reactive oxygen species, which leads to something called pulmonary capillary stress failure and eventually capillary injury. The presence of pulmonary hypertension in these patients preoperatively put them at an increased risk of anesthesia and surgical morbidity, and it is one of the relative contraindication in certain patients. So, what is the treatment? Restricted fluid therapy, administration of diuretics, nutritional support, and rest of the standard management like medical organ support like adequate oxygenation, may need, if need, mechanical ventilation. Even with all these, clinical outcomes poor with a mortality can exceed 50%. And if you have the facility, you can use inhaled nitric oxide at a concentration of 10 to 20 ppm. Some studies have shown that it can decrease mortality by as high as 30%. But in the same report also, there are other interventions which has been included like early intubation, The first sign of ARD is aspiration, bronchoscopy, and postural changes. These all have been advocated also. Postoperative hemorrhage, as we discussed, it may not be a very common complication but can happen. In open thoracic surgery, is less than 2%. In VATS, and for open surgery can be up to 1 to 3%. It's either a surgical bleeding or a coagulopathy. Standard coagulation test and check of transfusion with an FFP platelet cryoprecipitator factor 7 should be given as recommended. The catch is when to open the thorax. So if the chest tube output is more than a liter in 1 hour or more than 200 ml per hour for 2 to 4 hours, even after correction of coagulopathy, it indicates strongly indicated surgical bleed and dictate re-exploration. How to differentiate between a hemorrhagic pleural effusion or a frank hemorrhage? Hematocrit of the chest fluid can be helpful, and if the hematocrit is more than 50%, then probably it strongly indicates a uh, active bleed rather than a lymphatic leak. If the patient is hemodynamically unstable, but the chest tube is not draining anything, still strongly suggestive of acute hemorrhage, and in that situation, do a chest X-ray to show for the radiopacity of the same side of the lung, and most likely there is a tube block. And these complications are more common when there is a background of antiplatelets like aspirin or other antiplatelets like clopidogrel or ticagrelor or warfarin. So we need to remember that some herbs like garlic, ginseng, etc. can have an effect on the bleeding time and can prolong it. So discontinuation of all these herbs 2 weeks before lung surgery is strongly recommended. And what to do about the antiplatelet in the post-op? Usually we continue aspirin. We continue dual antiplatelet if there's a definite indications like different cardiac interventions. That means we continue 2 weeks after simple dilatation. For a bare metal state, cutoff is 6 weeks, and for a drug-eluting state, it's 12 months. Elective operations, if there's no urgency, it can be postponed, but problem is most of these patients are having underlying malignancy, so you cannot postpone the surgery. Clopidogrel, it can be a concern. So in high-risk patients who are at the higher risk of bleeding, we can hold it. Sometimes what we are doing is changing it to ticagrelor because it should be stopped 36 to 48 hours before the planned surgery, unlike clopidogrel, which sometimes we hold for 5 days during surgery. For warfarin, the recommendation is to hold for by 3 days preoperatively. What are the treatment of this bleeding? Conversion to an open thoracotomy if the bleeding is not getting under control and control the source. Look for injury to the pulmonary artery or vein. And in this regard, you have to consider or to take proximal control of the pulmonary artery before dissection of its branches. It's a safe preventive measure in an open lobectomy. So if you are not doing it, you may get a visible bleeding source. If there is a residual clot hemothorax, eventually we have to evacuate it either by a VATS or by open exploration to prevent development of something called trapped lung, and along with respiratory compromise and empyema. Cardiac complications, most commonly arrhythmias is atrial fibrillation. In up to 20% cases after lobectomy and up to 40% patient with pneumonectomy can present with arrhythmia like atrial fibrillation. Risk factors can be patient related like old age, pre-existing cardiovascular disease, postural changes, and limited pulmonary reserve. It can be surgery related like extensive procedure, intrapericardial pneumonectomy, extrapleural pneumonectomy, anesthetic agents like inhaler anesthetic agents, and it can be associated by major surgical bleed. Or it can be treatment related like previous thoracic radiation. It's mostly transient and self-limiting, and what you have to do, you have to control the heart rate. So what we usually do, we try to prevent it by optimal potassium and magnesium correction. And if the patient is on beta blocker, we like to continue it. If not, we may consider to start a beta blocker like selective beta 1 agonist or diltiazem. Continuous or recurrent paroxysmal postoperative wave to be managed with amiodarone or flecainide. Amiodarone is not a good choice if the patient has underlying lung disease or if the patient has undergone pneumonectomy. Incidence of ARDS is nearly 11% in patients who are treated with imidazole compared to only 2% for non-imidazole group who have developed in pneumonectomy patients. Flecainide is not a good choice if there's an organic heart disease and it can approximately double the rate of mortality and cardiac arrest. And in terms of the principle of rate control versus rhythm control, no difference in the rate of recurrent tape when the treatment of this uh, sh- new onset AF has been continued for 1 to 3 weeks or 6 weeks. So mostly in practice, we continue these drugs for 1 to 2 weeks till the stressor is there. We may need to consider anticoagulation if there is a standard two or more risk factors are present for stroke, like age more than 75, hypertension, impaired left ventricular function, prior stroke or transient ischemic attack, who has postoperative AF, and who that is persisting or recurring within 48 hours. If the patient has less than two or less risk factors and not suitable for warfarin, we can consider to give aspirin also in this context of 325 milligram OD. Oral metoprolol if the patient, for the purpose of rate control, if the patient was on a beta blocker, administration of magnesium, and the considered concern in regarding with anticoagulation is obviously leads to cardiac death. Ischemia, incidence of myocardial ischemia can be as high as 4% and even 1.2% can develop infarct. Patient usually present a hypotension and abnormal exercise testing, and this is the strongest predictor of ischemic event. Continuous monitoring is important for at least 2 days in high-risk patients. Thoracic surgery patients are usually considered a high-risk procedures by American College of Cardiologists and American Heart Association Society. So perioperative cardiovascular evaluation for a non-cardiac surgery need to be done in detail. You may need to go up to the vitamin stress echocardiography in certain patients, and some patients may also need to go through angioplasty when the surgery means thoracic surgery has been deferred for 2 to 4 weeks. What are the clinical risk factors for major adverse cardiac event or MACE? Functional status, poor functional status less than 4, history of myocardial ischemia, heart failure, cardiomyopathy, severe cardiovascular heart, valvular disease like severe aortic stenosis, symptomatic mitral regurgitation or stenosis, all type of significant arrhythmias, chronic renal failure, positive history of cerebrovascular accident, or is a history of TIA, diabetes mellitus who require an insulin, chronic pulmonary dysfunction, obesity, and anemia. There another interesting complication that can happen which is called right to left shunt. We know that in general population, patent foramen can be present up to 20% of cases. By some way, if there's an increase in the right-sided pressure, there can be a right to left shunt lead to a refractory hypoxia because of venous admixture. And here after that lung surgery, specifically pneumonectomy and right lung, then the risk of increased pressure in the pulmonary system will be very high. Usually the patient start developing symptom by 1 to 5 months. There will be platypnea that the patient is short of breath uh, while positioning, and orthodeoxia. That is, patient is short of breath when he is sitting and feeling comfortable if you make them lying down. And this happens because of the mediastinal shift and reversal of the intra-arterial pressure gradient during this positional change. There are factors which drive the shunt physiology like pulmonary embolism, RV infarct, increase intrathoracic pressure, COPD, positive pressure ventilation, and diagnosis can be done by in combination with ABG, nuclear lung perfusion scan, echo, MR, and cardiac catheterization. If that is there, surgical repair or intravascular occlusion of the septal defect need to be done. And in the patient who presents the hypoxia, we have to consider other differential diagnoses also, like pulmonary embolism, airway narrowing, and post-resection pulmonary edema, as we discussed. Cardiac herniation is a rare complication. Here, the patient presents with a cardiovascular collapse with jugular venous pressure or pulse pressure elevated and with cyanosis in the drainage area of the superior vena cava. Sometimes present with a ventricular fibrillation. It occurs through surgically created defect as a result of intrapericardial pneumonectomy or lobectomy with a partial pericardectomy. So, what usually happens? Usually a combination of sudden superior vena cava syndrome and heart side is in the right side of the chest. So treatment is emergency thoracotomy with positioning of the herniated heart into the pericardial sac and repairment of the pericardium. This is accomplished either by a suturing of the cuttage of the pericardium to the pericardium or by patching a defect of bovine pericardial patch, PTFE patch, or parietal pleura so that there should not be any gap. Heart failure, postoperative right heart failure is not that uncommon. This is mainly because of alteration in the afterload. And we know that RV end diastolic volume is okay after surgery, but gradually it increases in the POD1 and 2. And to compensate, there's an increase in the right ventricular end diastolic volume at rest as a compensation. Now, if the patient is going to do an exercise, there will be an increase in the PA pressure pulmonary vascular resistance, and there will be a reduced exercise capacity because of this mechanism. And eventually, if it keeps on progressing, they may have a biventricular failure or left heart failure. Post-pneumonictomy syndrome. This is again a rare complication. 1 in 650. Bronchial compression happens because of massive mediastinal sheath following pneumonectomy. More common after right pneumonectomy, young age, and female sex are the risk factor because they have a more elastic mediastinal tissue, so prone to shift, and a softer, more compliant airway, thus is subject to compression. The patient typically presents with an exertional dyspnea, stridor, recurrent pulmonary infection within 1 year of pneumonectomy. Treatment is airway stenting. As a bridge to therapy, this patient will need surgery. Definitive treatment is surgical repositioning of the mediastinum in the midline, and saline-filled silicone prosthesis is inserted into the pneumonectomy space. Lobar torsion and gangrene. Lobar torsion represents a rotation of the bronchovascular pedicle with resultant airway obstruction and vascular compromise, usually present with a high fever, severe chest pain, massive hemoptysis, bronchoria, and sepsis. Bronchoria is an important finding. Radiology shows abrupt consolidation and abnormal location of the colaflum, which is very, very important. Bronchoscopic contrast chest computer tomography or angiography can be done to diagnose it. Simple derotation or detorsion of and resection of the involved pulmonary segment if there is a poor vascular supply is enough, and pulmonary resection is mandatory if there is a gangrene. What are the other complications? There can be complications like chylothorax, prolonged air leak, injury to the surrounding structure, injury to the phrenic nerve leading to recurrent diaphragm, hemidiaphragm palsy, and injury to the recurrent laryngeal nerve causing vocal pulse, vocal cord palsy, and aspiration. So for chylothorax, it's again a rare complication. Less than 1% cases can be because of direct or indirect injury to the thoracic duct, which is the most common during dissection. Aggressive mediastinal lymph node dissection with the incomplete ligation of the lymphatic channel can be a cause. There can be subclavian venipuncture. And these patients usually have a nutritional deficiency, dehydration, and immunological deficient respiratory complications make them very high risk of postoperative complication. Early management is conservative with intrathoracic drainage insertion if not already present and total parenteral nutrition. Somatotropin analogs like octreotide can reduce the intestinal chyle production and in some patients can be considered. Eventual treatment is a surgical ligation of the thoracic trunk, specifically if it is draining more than 1.5 liter a day in an adult and more than 100 ml per kg per day in a child. Child leak as a rate of less than 1 liter per day for 5 days or persistent chyle flow for more than 2 weeks can be a concern. Air leak, I discussed a bit about this in the initial part, but mostly it is self-regular, self-limiting. It usually subsides by 24 to 40 hours after surgery. Only 5 to 10% need active management. It can be of two types, pleuropulmonary fistula or bronchopulmonary fistula. In pleuropulmonary fistula, the intensity of the leak is mild to moderate and appears during expiration. So insertion of an ICD with underwater seal and application of a low pressure negative suction should be enough. In bronchopulmonary fistula, there's a large and continuous air leak appears during inspiration and expiration both. So the timing is important. Definitive diagnosis can be done by fiber optic bronchoscopy and CT scan. And if the patient have an empyema, the prognosis is poor. In terms of management, antibiotics, if we are suspecting an infection, maintain posture to avoid spillage into the opposite lung, conventional surgical management to control the air leak, specifically if it is a large endobronchial therapy to seal small defects less than 5 millimeter can also be considered, specifically with a fibrin glue and silver nitrate. And airway stenting and sealing of the defect will be the next option. If there is a prolonged air leak, that means the air leak lasting more than 5 days, we have to look for the risk factors like emphysema, cachexia, lung pathology, anemia, hyperglycemia, COPD, history of chemotherapy, radiotherapy, hypoalbuminemia, previous steroid therapy, and so on. Management, again, even for this, 90% time it resolved with conservative management. And if the patient has a persistent symptom, we can consider for a blood patch or chemical fluorescence. And finally, the surgical management will be the key. Now, what we have not discussed in this session is the risk of infection. Now, these patients can have ISO-related infections like VAP, HAP, Klebsiella. It can have infections related to just disease, underlying disease like esophagus with a very high up stricture may have a high risk of aspiration. Someone with a CA lung involving the recurrent laryngeal lung may have vocal cord palsy leading to aspiration. Someone with a phrenic nerve pathology leading to hemidiaphragm movement, restricted diaphragmatic movement, and it eventually leads to beta lactosis and pneumonia. So this can be again a vast chapter, and we can discuss in another platform. So to conclude, surgical critical care is usually taken doesn't get its due respect. We need to be aware about all the anticipated complications that can happen in our patient, along with good understanding of the basic postoperative management like analgesia, pain, physiotherapy, and all, basic ventilatory support, hemodynamic optimization, and all. Along with this, knowledge of the anticipated complications and active search for any kind of early sign of those complications can be a key in the patient management in surgical ICU. So by this, I'd like to conclude my presentation. Thank you.